Good afternoon, everyone. To continue the discussion of this patient, probably this is the case of heart failure with preserved ejection fraction. As this patient is having a very high H2FF diagnostic tool, we have almost 6 or 7. I think this patient is having hypertension, atrial fibrillation, high pulmonary systolic pressure, her age is more than 60. So her H2FF score, I think it's between 6 and 7. So this is the case of heart failure with preserved ejection fraction. So what are our treatment option pre and just pre-discharge and post-discharge OPD management? So I'm going to discuss a few things about these things. So what are the treatment options we have? Even before a few years back, we don't have very positive trials on pharmacological management of heart failure. So all the trials on all the drugs that we used in heart failure disease fraction were negative. So in most of the cases, we manage these patients with management of comorbidities. Fortunately, now we have few drugs so that we can go for pharmacological management of heart failure too, and non-pharmacological management also is there. Next slide. So first at the management of comorbidities. So these are most important. So in heart failure with preserved ejection fraction patients, what are the main comorbidities we have? So atrial fibrillation, hypertension, obesity, sleep apnea, coronary artery disease, type 2 diabetes mellitus, and CKD. These are the most important risk factors for heart failure with preserved ejection fraction patients. Next slide. So I will discuss a very short few things about each of these risk factors. For hypertension is a most importantly identified cause of preserved ejection fraction heart failure, with a prevalence of 60 to 90% for this population. So what our target goal for blood pressure reduction? But as we don't have any consensus on systolic blood pressure reduction for this kind of patient, so we can follow the SSC guideline for general population, that is systolic blood pressure of less than 130 millimeter of mercury. But as per SPRINT, if the patient is having recurrent heart failure, even with this systolic blood pressure control, we can go for a more intensive control of for reduction in cardiac event, that is less than 120 milliliter of mercury. So what are our choice of therapy? If no compelling indication is there, the diuretics and MRAs are the first line of therapy for hypertension. Then comes ARNI, then ARBs, then CCBs. ARNIs are more effective in women and low normal ejection fraction patients. So for our patients, as we have this patient is hypertensive, we can use diuretics and MRA for this patient. But on the other hand, as the patient is hyponatremic and hyperkalemic, we definitely have to check our sodium and potassium level regularly to avoid this electrolytemia. And we definitely can use ARNI for our patient as an antihypertensive agent. If any compelling indications are there, like diabetic or CKD, we can use ACE inhibitor or ARBs. Then we can go for diuretics or MRA or RD or CCB. In this context, I want to share that beta blocker best to be avoided in heart failure preserved ejection fraction patient, as there is no positive trial with beta blockers if the patient doesn't have any coronary artery disease. Next. So next risk factor is coronary artery disease. It is also very common. The prevalence of epicardial disease is over 50% of individual. Microvascular dysfunction is up to 75%. No prospective trial to show impact of revascularization till now, but definitely symptomatic improvement may occur with revascularization of these patients. Here I want to add that routine use of nitrate without any coronary angiography or coronary artery disease is not recommended. It is class 3, no benefit for these kind of patients. So we often use nitrate in heart failure with preserved ejection fraction patient, but it is not recommended with no benefit. For angina, we can use ranolazine or CCBs are better choice than nitrates. Next. Obesity is one of the strongest risk factors. Obesity, more than 80% or more are overweight or obese. We all know how obesity works. It promotes hypertension, it promotes insulin resistance, dyslipidemia, sleep apnea, inflammation, it impairs diastolic compliances, it impairs skeletal muscles and exercise tolerance. So in heart failure with preserved ejection fraction patient, we must reduce the weight by exercise and dietary modification. This is very much beneficial. Pharmacological weight reduction with GLP-1 agonists like semaglutide may be significant, but still not recommended in non-diabetic patients for these heart failure patients. Atrial fibrillation, this is another very strong association. Almost all patients have indication for anticoagulation because almost all the patients have a very high CHA2DS2-VASc score. Due to the lack of clinical trial data in persons with heart failure with preserved ejection fraction, the comprehensive care of AF can be extrapolated from ACC/AHA guideline for AF. So what we do in most of the general population, we can do for these patients also. Rhythm control versus rate control is always a matter for debate. But in some patients, which patients are going for recurrent hospitalization for heart failure, rhythm control may give a better edge over the rate control. That rhythm control may be pharmacological or we may go for catheter ablation. Although no overall significant benefit on cardiovascular outcome has been noted with rate versus pharmacological rhythm control strategy yet. So individualized approach to symptomatic patients of AF may be needed. Next. Diabetes is a very often coexistence. Prevalence is around 40%. It's an independent risk factor, independent of CKD or higher BMI of coronary disease. So our target in lesser comorbidity patient or lesser severity of heart failure, the target HbA1c is less than 7 to 7.5%. And if the patient is very frail, older, higher comorbidities, recurrent hypoglycemia, recurrent advanced heart failure, our target HbA1c is less than 8 to 8.5%. So first drug of choice is SGLT2 inhibitor along with metformin. Metformin is also very important. GLP-1 agonist we can use for obese patients with diabetes. Dietary changes and lifestyle modification is never overemphasized. But it's better to avoid thiazolidinediones for fluid retention and saxagliptins. Sleep disorder, breathing prevalence is very high. Again, most of the patients are obese. So we have almost 60 to 80% prevalence of sleep disorder breathing. So in this context, the obstructive sleep apnea is most common risk factor, one of the most common risk factor for preserved vascular ejection fraction patient. On the other hand, central sleep apnea or CSA is a marker of heart failure severity. So we all know the sleep disorder, the symptoms, the daytime sleepiness, morning headaches, memory impairment, irritability, changes in mood, concentration, decreased libido, erectile dysfunction, snoring, epileptic gasping, choking, and witnessed apnea is all are the symptoms of sleep disorder or OSA. So we can go for either weight reduction for this kind of patients or a CPAP trial for symptomatic improvement and hypertension control. Next. CKD is another very important risk factor for this kind of patients. So what are the agents that can reduce the risk of progression of CKD in preserved ejection fraction heart failure patient? SE inhibitors, ARBs, SGLT2 inhibitors, and some non-steroidal selective MRAs like finrenon. So it's more important that we can use the SE or ARB inhibitor EGFR as low as up to 30. We can use SGLT2 inhibitor as low as 20. So up to 20, we can use SGLT2 inhibitors, and up to 30, we can use SE or ARP inhibitors. In this context, for ARNI, if the patient is on hemodialysis, we can go for ARNI even if the patient is on hemodialysis. We need to check the potassium recurrently. So, next. So this is the these are the comorbidities. Now we are coming to the treatment of this heart failure preserved fraction patient in OPD basis. So first is SGLT2 inhibitor. There is a 2A indication to start with. Almost every patient with this kind of patient, we can start with SGLT2 inhibitor. Then if the patient is having a fluid retention, we can go for loop diuretics, but you should keep in mind that is only symptomatic, no mortality benefit is there with diuretics. Then we can use MRA or ARNI for all women with all ejection fraction or with men with less than ejection fraction 50 to 60%. So we can use mRNA or RNA, MRA or RNA. This is a class 2B indication. And where we can't use RNA eligible patient, why we can't use RNA, we can use ARBs for those patients. Is another 2B indication. Next. So when to start SGLT2 inhibitors? Basically, SGLT2 inhibitors appears very safe and effective even when the patient is having acutely decompensated heart failure once clinically stable. So one patient is a bit decongested, we can use SGLT2 safely. In this IMPULSE trial, the empagliflozin was well tolerated, led to more rapid and thorough decongestion, associated with significant improvement in death, heart failure events, and health status. This benefit was of recurrent heart failure hospitalization was similar for every patient, and it's more than 50% or 60% fraction patient too. Next. So these are, I all know the two very important landmark trial for SGLT2 inhibitors with preserved or mildly reduced ejection fraction patients, the DELIVER trial, and next, another is next is Emperor preserved trial. These are empagliflozin and DELIVER trial for dapagliflozin. These two clearly shows us that SGLT2 is is a key drug for preserved ejection fraction heart failure patient. Next. Next, RNA in heart failure with preserved ejection fraction, two trials. Most important, Paramount trial. This is smaller sample trial, RNA versus valsartan. This is a significant reduction in NT-proBNP shows in this trial. Reduction in LA volume also significant, but this trial was not very significant regarding the mortality or morbidity benefit. Another trial that is more larger sample size, that is the Paragon HF trial, that is also RNA versus valsartan, LVF more than 45%, NOHA class 2-3, elevated NT-proBNP. So this shows a lower but not statistically significant reduction in hospitalization for heart failure. No reduction in all-cause mortality. So there is a 10 to reduction for hospitalized heart failure, but that is not statistically significant yet. But another thing is very important for a subset of patients when Paragon heart failure, a significant number of patients was in stage 2 and stage 3 CKD. But this RNA led to a slower rate of decrease in eGFR and improved renal outcome for this kind of patients. Next. MRA significantly improves the measure for diastolic function at individuals with heart failure. Specifically, the TopCat trial, significant reduction in rehospitalization with spironolactone in mildly reduced or low normal LVEF subset. So mildly reduced subset or low normal LV ejection fraction patients are more get more benefits from this mRNA like spironolactone or eprenol or finrenol. But appropriate monitoring of potassium and kidney function is also very necessary. Next. So there is a sex differential recommendation for RNA and MRA. Female with heart failure preserved ejection fraction responds more positively with RNA and MRA, recommended in all female population irrespective of ejection fraction. The simple explanation is for female population, the smaller LV cavity size and more concentric LV remodeling in female tends to overestimate LV ejection fraction. Next. Beta blockers, we do not use beta blocker as primary treatment for heart failure, but beta blocker may be used to treat chronic coronary syndrome or to control heart rate in AF. We do not use ACE or ARBs as primary treatment. Nitrate have class 3 or no benefit recommendation. Digoxin may be helpful in AF rate control, but no cardiovascular mortality. Loop diuretics are class 1 recommendation for fluid retention patients for symptom relief, but no long-term CV benefit. Next. So here are some contraindications. SGLT2 inhibitors, the type 1 diabetes mellitus, lactation, on dialysis, non-hypertensives, and for both dapagliflozin and empagliflozin around eGFR less than 20, you should not use it. On pregnancy, we should have a caution, mycotic genital infection. We should be cautious for this kind of patients. Next. Again, for MRA, for contraindications, potassium level, Addison's disease, pregnancy, and we avoid mRNA in eGFR less than 30 or CM creatinine more than 2.5. We can start In half dose, if EGFR is 30 to 50. Next. ARNI contraindication, we all know that 36 hours of ACE inhibitor we should not use. History of angioedema, pregnancy, severe hepatic impairment, we should, it's a contraindication for ARNI. Next. Non-pharmacological managements are there. Exercise and calorie restriction and weight reduction is very important for this kind of patients. Another is very recently, the pulmonary pressure monitoring by implantable pulmonary artery sensor, the CardioMEMS is very important. Class 2B recommendation it gets for remote PM monitoring because of the differential outcome in Champion HF, which is a positive outcome with CardioMEMS, but the guide HF trial is a neutral trial. That's why it gets a 2B recommendation. But as our patient is having a high pulmonary artery pressure, may have a recurrent hospitalization, may have a cardiorenal syndrome. So this patient is a suitable patient for CardioMEMS or remote pulmonary artery monitoring. Next.
Dr. Samanta, you may have to go to your last summary slide.
Next slide. So this is the last recommendation slide. The SGLT2 inhibitors have a 2A recommendation in heart failure with mildly reduced heart failure preserved or mildly reduced ejection fraction. Weaker recommendation to be made for ARNI, ACE inhibitor, ARA, ARB, and MRA and beta blockers. New recommendations for heart failure preserved ejection fraction are made for SGLT2 inhibitors. As we all know, treatment for hypertension is a class 1 indication. Treatment for atrial fibrillation is a class 2 indication. And routine use of nitrate and PD5 inhibitors are class 3 or no benefit. These are the newer recommendations. Thank you.